This is exactly why I do what I do. Just we work a lot with maternal oral care and dental oral care. So early on, you can introduce a muslin cloth, something soft, even a clean finger. And after feeds, you can just rub the gums after. Something as simple as that, just to build that in the routine for the child and the parent.
Welcome to NICU Heroes, a podcast produced exclusively for NICU professionals, with me, Kathryn Whitaker, as your host. I'm the mom of 6 children, including my very own NICU baby. This podcast is produced by Hand to Hold, a national nonprofit dedicated to providing free personalized support, resources, and community before, during, and after a baby's NICU stay. As a NICU professional, you've been well trained to care for the tiniest and the sickest babies every day. While a NICU parent's scars are not as visible, those parents are often as fragile as their babies, requiring patience, guidance, and encouragement to ensure that they are mentally, emotionally, and physically prepared to endure the pressure of a NICU stay. NICU Heroes is dedicated to helping NICU professionals like you better understand, support, and nurture the entire NICU family. Howdy, y'all. Welcome back to another great episode of NICU Heroes. We are almost done with 2025. Hard to believe. I can't believe that. But I wanted to, as we sort of wind down the year, I really wanted to focus on a topic that's a little bit near and dear to my heart, and that's pediatric dentistry. I naively thought, hey, so many things that our son encountered had nothing to do with his mouth. And I walked into that pediatric dentist visit with a lot of bravado and a lot of confidence, and it ended in a massive fail, like crashes and burned, so many wildfires that we had to put out. And as I looked back, I was like, oh, if I had only known. And so this is my If Only I Had Only Known episode for each one of you as a NICU professional. Dr. Lerman mentions in our interview that the mouth is the gateway to the GI tract. And how many babies in the NICU have GI issues? Answer: a lot. And so if I had only known some of the things that Dr. Lerman shared, it's possible that it could have, I don't think it would have eliminated everything, but it definitely would have made a lot of things easier. And that's my hope today, is that as you hear about the development of the mouth, things that we can do on the front end when they're in the NICU. So things that you can do at the bedside, not just oral stimulation with babies, but also oral education with families and caregivers, I think is going to be a huge benefit to you. But then also understanding what that means long-term, like some of the challenges or some of the things that kids and parents may be challenged with as they get older. And there were a couple of things that she mentioned in there that I was like, oh my gosh, we are changing that habit like today. And I'm not even talking about flossing. So these were just some great tidbits. And she has a lot of them in this particular episode. Great tidbits for you to think about as you're sort of educating and caring for the whole person, the whole baby in the NICU, but also helping the parents and the caregivers be great advocates for their babies, particularly with their oral health care, knowing that it really does provide a gateway to so many other parts of the body. I'm sorry if I'm nerding out on this one a little bit, but I think that you're really going to enjoy my interview today with our pediatric dentist. My guest today is Dr. Ashley Lerman. She's a board-certified pediatric dentist, mom, and entrepreneur who founded Firstgrin to make early dental care accessible and engaging for new and expecting parents. With a background in public health, she has led innovative programs and partnerships with major insurers, and she's active in promoting evidence-based preventative dental care on social media. She's a great follow, by the way. As a dedicated mother, she also champions women in healthcare leadership while balancing her professional and her personal life. You can follow her on Instagram at pediatric.dentist.mom. You are going to love this interview. So with that, let's get to a really great conversation. Dr. Lerman, thank you for being here today. I love when we get to nerd out a little bit on a specific topic, particularly in a specialty that you're really great at. So thank you for being here so that we can talk a little bit about preemie oral health and just kids in general.
Really, really excited to have the discussion. Thank you for having me. Yeah, this field, pediatric dentistry, is so niche, but really sets the stage for overall oral health down the line. So I'm excited to chat about it.
Your oral health affects so many other parts of your body, which is why I love chatting about things like that. But first, I want to go all the way back. So I always I like to give people some frame of reference as to why you chose dentistry or even medicine to begin with, and then why this little subspecialty of pediatric dentistry.
Yeah, that's such a great question. So my parents are in the field. My dad's a general dentist. My mom's a periodontist, which is a gum specialist. And I grew up always working in their office, answering the phone. And then if they didn't have stable childcare, I'd be in the back playing with glove balloons, things like that. So I was really, really interested in the field from the start. I like an experience where you grow with them, which is really important to me. I love that. And then in terms of pediatrics, I love how quick and behavior focused it is. I've always been interested in psychology, and there's a lot of it that goes into it from the parent perspective as well as the child. So it's really fun. You have to be flexible. If you're a parent, you know, plan A doesn't work, you need to have a plan B, plan C, all the way down to Z, and do the best you can.
Yeah, I hadn't even thought about that. I mean, yes, you're definitely treating the child, but I know that when my kids were little and we went to the dentist, it was as much about calming the fears of the parent sitting there as it is about getting the child. Because I think sometimes certainly kids sometimes have a fear of the dentist because they see all these tools as they get older, and then that may translate into them not wanting to go to the dentist when they're older, which leads to a lot of other things. So I love that you mentioned that.
That's exactly right. We also have parents come in all the time saying they have such bad dental anxiety from bad experiences when they're kids. And I think the climate has changed a lot around preventive dentistry, preventive oral care, and setting a healthy stage early on so kids get comfortable, feel trustworthy. Because I definitely have kids coming in, no, don't give me shots. I'm scared of the dentist. And, you know, kids also pick up on parental anxiety. They're very, very smart. So if they
Yeah.
feel their parent is anxious, they may feel unsafe in the setting too. So we try to work together as a team in that sense.
Well, or they may not have. I know when I would go to the dentist, I would have my stroller and all my kids, and so they got to see me in the chair. But I don't know that I ever thought later that that might actually benefit them because they saw me at the dentist. But it can be a scary place for anybody, whether you're 2 or a little older than 2. So maybe let's go all the way back to neonatal intensive care units. So babies, a typical developing baby is born and then they go home. But a neonate finds themselves oftentimes in the NICU, and there's a lot of stimulation to the mouth. It might be a CPAP. It might be maybe they're not even able to take feeds by mouth, so they're not using the normal suck, swallow, breathe for a little while. So maybe let's chat a little bit about what that does for you when they land in your office and sort of some of those oral challenges that they might be challenged with that a typical growing baby may not necessarily have.
Yeah, I think that's a really good question. I think it comes back to stimulation. Were they feeling overstimulated? Is there this deep rooted feeling of, too much sensation to the mouth? So we could see that too. I think ultimately it depends when the child's seeing the dentist. Like as a pediatric dentist who's worked in hospital settings, we've seen NICU babies, usually under the guise of analyzing ties, tongue tie, lip tie. But then it goes back to overall medical stability too for when we'd address that. So when it comes to getting comfortable in the dental chair, we want to make sure the child is exposed and has a good positive experience with that. When it comes to NICU babies, it'll take a little bit longer for them to get to that point, more awareness, but exposure is good early on.
So what do you think, Dr. Lerman, when you see a baby that has a complicated medical history, they're coming in and you're not the first specialist that they've seen before. What are some things I think that they might be extra challenged with sitting in your chair?
Yeah, so it depends on the age and the behavior. A lot of the times when we see young patients, let's say a 2-year-old who had cardiac surgeries early on after being a preemie, the parent usually discloses the child's a little uncomfortable in a medical setting. Always giving that heads up is really, really helpful for providers. So we can address it, maybe talk a little bit more to the child. 2-year-olds is obviously very different than like a 6-month-old coming in if their first tooth comes in. But again, I think that's where parental communication really helps, giving the full background. A lot of times when people come to the dental office, they won't tell us the full medical history. They may not mention that the baby was a preemie, though there's a ton of correlations with data for preemies and dental health or how some teeth come in, things like that. So I think it's important for parents to be aware of that because often the mouth is just treated as a separate part of the body for whatever reason.
You mentioned the heart. So let's talk about why that is such a big deal for dentists, because our son had a couple of heart defects. And as soon as I said that, my dentist was like, oh, hold on, let's talk about that. So why did we need to talk about that?
Yeah, so we always want to talk about heart, any surgeries, things like that for antibiotic prophylaxis, for example. When it comes to cleanings, we want to make sure there aren't any bacteria in the mouth that could transfer down to the heart and cause complications like bacterial endocarditis, excuse me.
All right. So whenever, maybe let's back up a little bit about the difference between if a parent is bringing in their baby for the first time or their young child to the dentist versus them as an adult going to the dentist. What is it that you do differently that allows you to sort of focus and have that niche sort of pediatric dentist role as opposed to just like when I go and make my appointment to go see my adult dentist?
Definitely. So setting the foundation, AAP and AAPD recommend the first dental visit within 6 months of the first tooth coming in or by age 1. That's generally recommended. So the reason we want that to be so early is because we ultimately want to prevent disease from happening. So it's different when you have a baby with no teeth coming in or very few teeth because you can alter behavior from the parent and how they're cleaning the baby's teeth, how they're approaching diet and nutrition. Whereas with an adult, behavior in an adult is historically very challenging. For example, tobacco cessation, working on nutrition, changing our diet. So it can be, there are much more complex factors in an adult theoretically versus with a child.
So when a child comes in, Dr. Lerman, and maybe I know that some of them have, because of all the oral, I guess I hesitate to say abnormal, but because of the excessive oral stimulation that they got that other babies don't typically get. What are some things that you do to sort of address, maybe they have sensory processing disorder, or maybe they just have a lot of sensitivities orally that they may not have in other places of their body? How do you manage that?
Oh, it's such a good question. I think, again, talking to the parent, discussing how, with overstimulation and, a resulting sensitivity to it, stressing how normal that is to the parent. Because sometimes parents feel embarrassed or ashamed or think their child should be perfect in the chair. When pediatric dentists, we are used to all types of behaviors. We want to make everyone comfortable. And that looks different for every single person. So we may give different tips for how to make it more comfortable in addressing the mouth. So if you take a toothbrush and gently use it on the baby's cheek, or when the baby's able to, let the baby play with the toothbrush and kind of get used to it themselves, play with it near the mouth. So sensory experimentation in that way, things like that have been shown to be improving behavior in the dental chair.
So how do you do that, Dr. Lerman, if a child, like, I'll use my son as an example. I had major challenges with oral stimulation, and it took us a long time of working like with a feeding therapist as well as an occupational therapist, along with his dentist. Like it felt like we went to dentistry school every time we went, because I was like, I felt like and certainly if it was a new hygienist, I was like, okay, so let's sit down and let's talk about this. So let's talk about that integration, or maybe that overlap in care between therapists, maybe that are focusing on feeding or occupational therapy, and then what you do as a pediatric dentist. And then also the other person that we haven't talked about is the hygienist. So there's a bunch of people involved in that process.
So many people. I love that you point that out because I think that interprofessionalism is huge, huge, huge. When it comes to swallowing therapists, OT, we make those referrals all the time. And if a parent is seeing the pediatric dentist for the first time without seeing those specialists, they may not even know that they're an integral part of the web of care. So we always want to make sure the parent feels comfortable in navigating that system. It could get challenging navigating referrals. We know how that is. So being open with the dentist to, hey, can you break this down for me? Offices tend to be really good about that. If you express that, it's, open lines of communication. And then hygienists, dentists, again, making sure everyone's on the same team, the patient, and knowing that it'll take time as well. And then I think outside of the dental office is just as important because, especially before a first visit, the child's a little older and aware. You can go through a YouTube video, a little book of what to expect, because the dental setting is so sensory overstimulating with the lights, the sounds, the smells. So just prepping the stage for that in some sense. You can even look at pictures of the tools and knowing, hey, this mirror is going to go in your mouth. It might feel cold, and talking about what those experiences might feel like.
Are there places that people can go, Dr. Lerman, to maybe find a pediatric dentist that might be more amenable to that? Or is that just something that every pediatric dentist is trained in? I want to give families an idea. I'm thinking about like, so the NICU professional with their, and when they're in the NICU with a patient and they're like, hey, just what you said, when a first tooth appears or by a year, you need to go see a pediatric dentist. Sometimes it feels overwhelming to just find a specialist in general. And because they have maybe some more medical needs, what would you suggest on how they find the best dentist that's the best fit for their baby?
Definitely. So pediatric dentists across the board are trained to work with young children from the start. That's what we get our extensive training in, as well as generally people of all ages with special healthcare needs. So we are the go-to. I know some people will call family dentists, and the family dentist will say, bring them in at age 3. The guidelines say by age 1 or 6 months within the first tooth. So if people are looking for resources, AAPD, which is the American Academy of Pediatric Dentistry, has a list of providers that will be able to see your young baby. And if for whatever reason, you call a family dentist and they say, don't bring them in before age 3, I urge you to take a look at a pediatric dentist because they'll tell you otherwise and bring you right in.
That's good advice. So when we think about the exam itself, there's so many things that are moving parts in a mouth that you're like, there's this and there's that. So give people an idea of what some of the things are that you're screening for, that you're looking for, and then some of the things that may cause concern, like, oh, if I see this, then that might mean that we need to start looking into this.
Definitely. So it's definitely going to depend on the age of the child. If we're looking at a child with no teeth yet, we're looking at the soft tissue mostly. We're looking at ties, what that may look like. We're assessing form and function. I know tongue ties, lip ties are such a hot topic, but if we see a tethered piece of tissue, it doesn't automatically mean we need surgery. If something's being affected, we might take a look in that route. We may offer myofunctional therapy. That's another professional we work with very closely. So a lot of the history from the parent is going to be really important in our treatment as well.
I'm going to pause there real quick because you talked about the tongue tie part. So how do you know if that's something that needs medical intervention or if it's something that you just watch? Like, what would be some of the things that you'd be like, oh, we definitely need to send them to a specialist to have that looked at?
So a really, really popular one, especially for young babies, is latch when it comes to breastfeeding or feeding difficulties, any clicking, things like that. We really want to talk closely with the parent to see what their experience has been like, how old the baby is at that age, overall medical stability, if we're talking about preemies, as well as feeding readiness, developmental maturity. There are so many things that go into it, but working closely with how feeds are going from the parent is going to be really helpful. And then we may work with a lactation consultant, interprofessionally, things like that.
Right. Okay. Sorry, I didn't mean to interrupt. All right. So we were talking
No,
about tongue
not
ties.
at all.
Yeah. So what might be some of the other things that you're looking for, that you're concerned about, or that you're keeping an eye on?
Yeah. So I think some other things that people don't realize is the mouth is the beginning of the GI tract. So we're actually able to catch early GI diagnoses, let's say Crohn's disease. Certain cancers may present from bleeding gums. So we want to hear if your child has bleeding gums at home. It could be something as simple as gingivitis and you need to do better with brushing and flossing, or we may want to send you to a hematologist for a blood count. So that's what I think people fail to realize a lot of the time about dentistry, how interconnected it is with overall systemic health. So we're able to catch those things early, like I said.
So what would you see if someone did have Crohn's? What would be an indicator that you would see as the dentist that they might be a candidate for that?
So that's something called cobblestoning of the gums. It's a little niche and like oral pathology sounding, but it's just dimpling on the gums. You can Google a picture of it. It's a little hard to see if you're looking in the dark. That's why we use our loupes with our light and we're able to see really well. But then again, like my son had hand, foot, and mouth disease, and I saw soft tissue on the soft palate, signs of that as well. So there are a lot of signs that we may miss in the mouth because we're not able to do a good job looking at home.
Right. Well, and sometimes when you're in the chair, you sort of have them in a unique position. I know sometimes I'm like with the flashlight trying to look at my kid's mouth and they're completely uncooperative. It never works well.
My son's the same way, to be honest. So it's helpful for me as a parent to see what, the toddler behavior is like, what challenges come up, because my child's not one who likes brushing. So we have to be creative. And then I'm able to talk to other parents who have similar struggles.
That makes me feel better to know that even the dentist has problems getting her child to brush his teeth. That's good.
100%.
I want to dive in a little bit to maybe kids who have significant oral issues. Maybe they have a cleft lip or they have a cleft palate, and obviously sometimes that presents at birth, and then sometimes that's something that you may not discover until later, depending upon the severity of it. So if a baby comes into the NICU and has either one of those things, how does that does that accelerate medical care? Give us an idea of what that might look like.
So cleft lip, cleft palate cases are so intercollaborative. There's going to be a feeding specialist. I know we work with special prosthodontists who can make what's called an obturator so the baby can feed, which essentially plugs and creates a seal so the baby's able to effectively suck and swallow nutrition. When it comes to pediatric dentistry for cleft lip and palate, what's mostly looked at is the timing of the teeth, where exactly the cleft lip and palate occurred, because it may result in agenesis of teeth, which means that the teeth were never developed. So it's something that we track long term as a pediatric dentist, and we often work with an oral surgeon who will revise the cleft lip or palate closely. So we're able to follow the child as you get older. And then once they're of age to potentially get an implant, usually around 18 years old, there's a whole path of dentistry. So I guess that's all to say that it's going to be very interprofessional among different specialists.
Yeah, I know that sometimes when you get a diagnosis, depending upon where it is and the severity, it sometimes feels overwhelming. And then when you realize, oh, I can't just go to one specialist for this, there's multiple specialists. Sometimes it can feel not only overwhelming, but like, where do I start? What are the things that I need to know? And then how do I process that to get them the best care? I know that sometimes that feels like it, or it can feel like a lot. So thank you for giving people a little bit of an idea of what that might look like.
Of course.
So long term, like when we start thinking about maybe a baby that was on TPN for a long time, or a baby that ended up being pretty orally stimulated because they had a pacifier for a long time, like what are some long-term effects of some of those things that you see as your patients get a little bit older?
Yeah. So when it comes to pacifier or some thumb sucking, anything that has that motion, we know that long term it can affect the jaw development, the teeth alignment development. So, according to the guidelines, AAPD says as long as you stop it by age 3, it won't have long term effects. Specific studies actually show earlier is better to wean off of. A lot of parents, and I personally like timelines to know concretely when to start weaning off. So, generally at 6 months, I say to parents, if you're using password, try to wean it only to nighttime. We ultimately want to get rid of it completely by 18 months to have it already done and completely done with by age 3. That's going to look different for every single person. My son loved the pacifier. I have 2 under 2. So when my newborn had a pacifier, he saw her have it. He was older than 18 months and he would grab the pacifier too. And I was just like, let him have it. So you want to pick your own battles. I want parents to feel supported
That's
and
good.
not shamed. There's so much shame around like everything in the medical world, and just parenting isn't really like that. You know, it's there's theory and then there's practice.
Thank you for saying that, because I do think, at least I know that when we left the NICU, I felt like there was a long laundry list of checklists, like,
Yeah.
you must do this, please do this by this month. And anytime we either didn't meet that milestone, or it was something that I was like, oh, we missed that, the guilt just starts to add up. And then you start to think, is this medical intervention that we did, could I have prevented that? And you start to go back in time. And I think, man, we were just trying to survive, much less, get to the next thing. Like the idea of, oh my gosh, did I get rid of the pacifier at this age? And if I didn't, now we're going to have to spend $7,000 in, orthodontics or whatever it is, but it can feel like a lot. So thank you for that.
Totally, totally. No, you're right. And thinking about the guilt and the shame, and we're just trying to do our best and have our baby feel comfortable. Like non-nutritive sucking is so natural, right? It soothes them, it comforts them. You want your baby to feel safe and protected. And at the end of the day, is the pacifier habit really that big of a deal? I personally don't think so. You'll probably find providers who think otherwise. But I'm big on the parenting aspect, what's realistic. I'll tell you what the data says, and I'll tell you what the should and what the map should be. But you know what's best for a family behind closed doors.
So best practices for if you're trying to instill good oral habits from the very beginning, even when they're maybe just born or maybe when they're just in the NICU, like what are some things, small things that parents can do that may end up having big dividends as they get older?
So I think one of the biggest things pediatric dentists stress is brushing the gums and teeth early. What that's going to do is help desensitize, get baby used to the feeling of brushing. So using a gum brush, a muslin cloth, things like that over the gums once in a while before teeth come in, getting into those habits, building it into the routine. It's just as much for the baby as it is for the adult. As soon as that first tooth comes in, it's recommended to use a soft bristle toothbrush twice a day with a rice or smear size amount of fluoride toothpaste. That's what the guidelines say. It's much easier to brush a 6 months old's teeth rather than a 15 months old's. We know toddlers, they're independent, they're fiercely independent. My toddler, again, like I said, did not like brushing his teeth, but we built it into the routine from the start. So he was used to it. And similar to a diaper change or putting a baby into a car seat, it's non-negotiable for health or safety. Sometimes it's hard. They don't like it. They yell. Get it done efficiently and then positive praise, reframing it, and then move on. They are very resilient.
Thank you for that. I think that I think maybe sometimes we fear like, oh, we should just wait until they have teeth, because I know a lot of time, like when I was a brand new mom, I was like, well, if they don't have teeth, why does it matter? But I don't think I realized the connection. It's not until my kids got older that I realized this connection between oral health and long-term health. I know you mentioned that at the very beginning. So maybe let's turn it back to that, because there are a lot of things connected to the mouth and our oral health that really does affect the overall health of us. So as you're getting older, what are some things that if you see that in the mouth, you're like, I know you mentioned about GI issues, but I'm thinking about as kids get older, what might be some red flags? Like if you see it, you're like, oh, that's a sign that something else is going on.
Yeah. So again, like I think the mouth really is a gateway to overall systemic health, mostly for GI issues, certain types of cancers, certain types of blood disorders as well. But I think even further than that, we overlook the fact that cavities are kids' number one chronic disease. And I hear all day, every day, baby teeth don't matter. What I think people fail to realize is there's a large correlation between disease in the baby teeth and disease in the adult teeth. Baby teeth don't all just fall out one day. There's a phase between 8 and 13 years old where there's a mix of baby and adult teeth in the mouth. So if you have unhealthy, cavity-ridden baby teeth, that bacteria can spread to those adult teeth and cause decay from early on. The 6-year adult molars are the number one most diseased teeth. We get those at 6 years old. People often don't realize that. They're all the way in the back of the mouth. We may or may not realize that they're in the mouth already. So if we're starting off at 6 years old with cavities on an adult tooth, it's really setting the stage for more issues down the line. That's why I like to stress, set that early healthy foundation early on. Do your best with the baby teeth just to ultimately protect the adult teeth that we want to have for the rest of our lives.
I hadn't even thought about them. I mean, I know my kids, I feel like we have 6 kids, so I feel like teeth are falling out all the time at our house.
Oh
But
yeah.
I'm not the tooth puller. I'm the one that does everything else, but I require my husband to pull teeth. I was like, I do a lot of things, but you got to be the tooth puller. So I don't know that I thought about that juxtaposition of having adult teeth and baby teeth, and then differentiating, like, if you don't take care of all the teeth. We used to joke with our kids, only brush the ones that you want to keep. And then my kids would be like, but they're all going to fall out. And I think for a long time I was like, oh yeah, that's true. But now I'm too late now. I'm 6 kids in and my youngest is 10. But as I'm thinking about this installation of good habits, because you don't get another set. I know my kids were like, well, when they would get their permanent teeth, they're like, it's fine. These will fall out and I'll get another set. I was like, no, you only get 2. And sometimes you don't get a tooth, like for whatever reason, that tooth doesn't develop and you just get the one. So sometimes there's crazy things that happen in their mouths. And I'm like, you just don't know. But thank you for reminding me that I need to take care of all those teeth. I hadn't thought about it that way.
Of course. Yeah. I think reframing it, we're just in a day and age where stressing prevention is really big. Like even from when I was a child, my parents are dentists and I had so many baby tooth problems. Pediatric dentistry prevention wasn't stressed. It was very much a model of see disease, fix disease. Mm-hmm. And now the conversation is more going upstream to prevent disease ultimately, which is what I love. And I think parents are such an interesting cohort because they're so motivated to do what's best for their children. And they learn something for themselves as well.
Yeah. No, I mean, I don't remember ever going to a pediatric dentist. I just went to the dentist that my parents went to as a young kid. But then when I started having kids, I remember my mom asked, "Why are you taking them to a pediatric dentist?" I was like, "Because we have one, first of all, and two, like it's more fun. Like my kids enjoy going there for the most part. They love they're treated in a more fun, unique way. They're more sensitive to the things that kids are dealing with as opposed to what adults deal with. And I think that I appreciated sort of the focus on them as opposed to the focus just on the teeth, but it was like the whole person.
That's exactly right. Whole person, mouth to body, as well as the psychology behind it, because that's a huge part of it. So I'm glad that they felt comfortable and welcome, because again, I do think that's really important.
Yeah. All right. So you mentioned cavities. Let's talk about cavities because I feel like, I don't know. I want to say that my preemie had more cavities than his siblings. And I don't know if it was because of some of the oral challenges that he had, maybe just the propensity of what was going on with him medically. But those tend to be the biggest stressor in any family's household of when you get back from the dentist. Did you have cavities? And if you did, how many? And then why are we getting them? So let's break all that down. This podcast is produced by Hand to Hold, a national nonprofit, but we're more than simply a podcast. Hand to Hold is here to support your NICU in two ways. One, you can refer your NICU parents to us for support, or two, you can bring dedicated Hand to Hold support to your NICU, either in person or virtually. Our support consists of one-to-one group and educational resources, including our family-focused podcast, NICU Babies Parent Support. For more information, visit handtohold.org and click on NICU Professionals.
When it comes to preemies, we can talk about, there's some data that shows that there may be a higher risk of hypomineralization. So the teeth may come into the mouth a little bit weaker. So if the teeth are a little bit weaker, they may be more prone to cavities. The way cavities ultimately start is a bacteria feeds off of acid in the mouth. Feeds off of like simple carbohydrates in the mouth that makes the mouth acidic, which makes it prone to cavities. So for parents, the take-home message, ideally, early on, the biggest thing is if you're sipping milk throughout the day, if you're snacking throughout the day, those are huge risk factors for cavities. It's often not spoken about. On top of that, you want to be brushing twice a day with the fluoride toothpaste. You want to floss as soon as two teeth touch. That's often overlooked because when I talk to parents about flossing, they're like, I can barely brush. What are you talking about? That's going to be a rodeo. Totally relate to that. My child's the same way. There are a lot of different positions, and that's something I think pediatric dentists can really help with, like effective positioning for being able to toothbrush, to floss, to actually see in the mouth. But again, talking about diet, nutrition, what type of toothpaste you're using, flossing, all of these things play into the bigger puzzle of cavities. It's not binary. It's not you have a cavity, it needs to be fixed. You may have the start of a cavity. Can we stop it from growing by changing our habits at home? So those are, I think, are the conversations that are worthwhile having with the pediatric dentist to tailor it to the individual family's need.
So you talked about what they're drinking. So babies, whether they're drinking breast milk, whether they get older and it becomes, some sort of milk, whether that's cow milk, oat milk, whatever, juices. So maybe let's talk about the things in which kids tend to suck on and consume throughout the day that maybe adults don't do quite as much, but certainly as they're developing teeth, how that can affect what happens to their mouth.
Yeah, a huge conversation in pediatric dentistry is nighttime drinking. So when we're talking about milk, we see this phenomenon called early childhood cavities, where we see a specific pattern of when the baby's falling asleep with milk in their mouth, the tongue pushes it up against the front four teeth, and we see this very distinct pattern. What we often tell parents is you ideally want to brush or wipe the teeth afterwards so the milk doesn't sit on the teeth because there are natural sugars in milk. Is that realistic to do in the middle of the night? You have to figure that out for your family. Most of the time it's not, and I understand that because you're exhausted. You just want the baby to go back to sleep. So in that type of scenario, just aim to brush the teeth first thing in the morning. It's all about the frequency that the teeth are exposed to certain types of sugars or acids, essentially.
So is that milk, whether it's breast milk, cow's milk, all the other kinds of milk, or is it just a specific kind of milk?
So generally all types of milk, generally with breast milk, there were studies that show that increased cavity risk as soon as you introduce food, introduce solids. But from the APD, it's generally said any type of milk because it is, again, that natural sugar sitting on the surface of teeth for extended periods of time.
Are there certain foods, Dr. Lerman, that if a child is eating those, that they're like going to have a higher propensity, not just for cavities, but just like long-term oral challenges?
Generally, things that break down to simple carbohydrates, because that breaks down to sugars in the mouth. So we obviously know gummies, soda, juice, those things are ridden with sugar. But what we often overlook is things like goldfish, crackers, pretzels, things that are salty, but they also break down to sugars and they also get jammed in the grooves of your molars. So that's a really common spot for cavities to start. So we are having those snacks. Some countries, if they have snack time, they'll introduce a raw carrot or apple to help naturally clean out the grooves. But you just want to think about things not sitting on the teeth for long periods of time.
Yeah, what are some of those foods that are good for your teeth that you're like whenever you eat that it's like a palate cleanser? So what would those
Yeah.
be?
So raw, crunchy veggies and fruits, those are obvious ones. Cheese is another good one. Once the child's old enough, things like nuts. Meat is also a really good one as well. Seaweed, tofu snacks. People like to use those. But again, like if you're a balanced parent, my child loves crackers, loves chips, things that are crunchy. So I just want to think about A, if we could give him something fresh afterwards, or B, trying to get the stuff that's jammed into the grooves of the teeth out as soon as possible. But make it realistic. I don't want parents to be obsessed and like reeling about what that does to their teeth overall. It's just something to think about that's not often discussed.
Right. All right. So let's talk about the role of water. I know everyone keeps telling us how good water is. How good is water for the mouth, Dr. Lerman?
Water is excellent. The reason being that it basically helps buffer and flush the mouth. So saliva is a natural buffer for the mouth. It helps protect against cavities. So what water does is can help stimulate saliva or just brush, kind of flush the teeth too. So if we are having those snacks, giving sips of water afterwards is helpful. And one distinction I want to make is that seltzer water is acidic. There's carbonic acid in seltzer water. So that can also make your mouth more prone to cavities if you're sipping on it all day through the day. So it's better to have it in one sitting rather than exposing the mouth to it constantly.
Yeah, we haven't even talked about carbonated beverages. How do you feel about those?
I personally love them. I grew up with them, but I'm so much more aware of how I'm drinking them too. I love coffee, but now I'll be more focused about drinking it at once rather than through the day because it's just healthier for your teeth that way.
I hadn't even thought about it that way. If you just drink it once as opposed to drinking it throughout the day. So you're talking, so essentially that's an exposure thing, correct?
That's exactly right. We're thinking about there's a thing called the Stevens curve, which talks about the pH or the acidity changes in the mouth. So if you have it in one sitting, it's going to dip down into an acidic zone once, whereas if you're sipping it through the day, it's dipping down into the acidic zone constantly. So you're more prone to cavities in those cases.
Okay, that's fascinating. Now I'm thinking about how I'm drinking. This is for me now, not just my kids, but oh, that's fascinating. So yeah, so I'm like, okay, yes, you can we're Dr. Pepper drinkers at our house. Not a ton, but I mean, I am from Texas. It's sort of like
Yeah.
part of our DNA down here. I love that. That's really good advice. Particularly if it's something that you or your child enjoys. It's not that you necessarily have to get rid of it totally, but just thinking about how and when you do it and then what you follow it up
100%.
with. I love that.
That's
That's really
exactly
good
right.
advice.
And it's realistic too, right? Like I'm not going to say never drink soda. I like soda. I'm going to drink
Sure.
it ideally with a meal, not throughout the day, and try to drink some water afterwards. Those kinds of things and small changes can really go a long way.
Sure. So does it matter whether you drink a liquid just orally or with a straw? Is there a difference? Is one better than the other when it comes to exposing the teeth to certain things?
Technically, drinking through a straw is going to expose it less, but it's not something I would fixate too much on. That's not
Okay.
really going to be the make or break. If it comes to focusing on something that you can change, it would be the frequency and then following it up with some plain water.
Okay. Yes, these are things I'm writing down so then I can tell my kids, "What did you learn today, mom?" And I'll be able to tell
Oh,
them, "This
that's
is good.
amazing.
This is
I
good."
love it.
All right, so let's talk about sealants because I know sometimes sealants, some dentists believe in them, some are like they're not as important. So give us an idea of what it is a sealant is, what its function is, and then what you feel like its efficacy is whenever kids are getting older and their teeth are getting bigger.
Yeah, so sealants are essentially a protective barrier on the grooves of the molar teeth, so the back groovy square looking teeth. There is excellent data to show that sealants are protective against cavities, specifically on the chewing surface of the molars. There are different types of sealants. Across the board, I would think there are a couple of things to consider. I think if you're high risk for cavities, it's a no-brainer to get sealants. I would want all my kids to have sealants to protect their teeth. There's really good, like I said, long-term data showing protection against those teeth. Another thing to consider is the insurance aspect, that's what makes dental care a little complicated in the country. We can talk about dental insurance. It's essentially a glorified coupon. We hear about it all day, every day. People are very frustrated with the system. But generally, sealants are covered by insurance companies for the 6-year molars as well as the 12-year molars because it shows good return on investment, that it will protect the teeth and save money down the line. So I think that says something. If insurance companies are buying into it to save money and to save need, it's pretty good data to show that they're effective.
I'm glad that you mentioned a little bit about the insurance part because I know sometimes people have medical insurance, but oftentimes they may or may not have vision or dental insurance, or they might be on a state funded Medicaid, or they may be on the CHIP program. So there are limitations as to what kids and families can receive and what they can't receive. I guess knowing those limitations, Dr. Lerman, what would be your priorities and in kind of a breakdown mode of if you can do this, these are things that I would absolutely 100% recommend. And then if you can do these things, even better, but sort of giving people a hierarchy of if insurance or funding is an issue in your particular family, what are the priorities of things that you should really focus on first and then kind of go down from there?
I think it's a really good question. I'd urge people who do have dental insurance or even state coverage to see what that covers. A lot of the times it's very heavily preventive focused procedures. So cleanings, checkups, sealants, fluoride varnish, things like that. All of those things have long-term data to protect the teeth from disease. When it comes to things I recommend, early visits, under CHIP, every child is covered generally for those preventive care visits, check state by state as well as individual care under that. And then when it comes to dentistry, I think people get a little skeptical about dentists. I've heard it myself. People feel like it's kind of used car salesman-y. You don't know what's going on in there, so you have to trust someone to be telling you the truth. And also there are different philosophies with different dentists. So if you're concerned about a treatment plan, I always urge people to get a second opinion. Talk to people, see what you could do at home to try to do better with the home care, diet, and behavior. Because even if you get a cavity filled, if you're still doing what you're doing at home and propagating this disease process, drinking juice throughout the day, the cavities are going to keep coming back. So It's really just this full picture, not just in the dental chair, but what's going on at home too.
Okay, thank you. So if you're going to prepare a child, let's say that they're maybe a little bit older, babies are slightly different. You can't really reason with a baby, but as a child starts to have better cognitive ability about what's going on at the particular doctor visit that they're at, particularly when they come to the dentist, Dr. Lerman, what are some things that a parent can do or a medical professional can do to help ensure that they have the best possible visit, even if they may have oral challenges or sensory processing disorder? What are some things that you can do on the parent side? And then what are things that y'all do on the professional side to ensure that it's a good overall visit so that maybe in 6 months when it's time for them to come back, that they're maybe less scared and maybe a little bit more confident as they walk in?
Definitely. I think as a parent, I mentioned a little bit before, but having a script beforehand for what to expect, showing images, reading a book, going on YouTube, there are amazing free resources out there to prepare parents for talking to their child about their first dental visit once they're a little more aware.
Do you have some suggestions of what those might be, like some of those books or some of those resources?
Yeah, so I know Blippi has a first dentist visit, which is really good, really helpful. When it comes to the medical or the dentist, the medical office, if your child has specific challenges and you feel a certain way, like, they're very sensitive to noise, you can call the office beforehand and let them know so they can be prepared, because even if they may not be able to change the volume of what's going on, they know to have a script ready for the family for setting the stage, saying, oh, we're going to use this instrument. It's a little loud. get ready. It's going to sound like this. It's going to sound like a bumblebee. It's going to sound like a motorcycle, using kid-friendly language so they're more aware and it's not so jarring. Same thing with the light, having sunglasses ready if they're triggered by strong light, things like that. So pediatric dentists, I joke that we're part magicians because we have all these like tools and instruments to help us out. And then of course, at the end of the visit, oftentimes kids are crying because they're scared, overstimulated, reframing it, saying, wow, you did amazing. That was such a great visit. Aren't you excited to come back in 6 months? Getting a prize, things like this really, really, really help.
So if there's a child that has to have more intervention than just a dentist, maybe they have to go to a surgeon or a more specialized dentist, what are some things that might lead them to that? Like why might they not have to go to a specific dentist for something different when it comes to the surgery part? And then how do you prepare them for sort of advanced care more than just cleaning their teeth or doing some exams or pulling a tooth or some things that you might do in your office?
Yeah, I mean, I think behavior management is a huge part of our training as pediatric dentists. We run the gamut from simple to more advanced. We often see that if a child needs to be sedated, for example, for a full mouth of cavities. We often see that. We see 3-year-olds come in and they have 8 cavities between their back molars because parents aren't flossing. And we have to see, will the child be able to tolerate that much treatment in the chair? Because it may take 4 visits. It really, really depends a lot on behavior, what the child will allow, what the parent wants. So we always want to discuss the risks, benefits, and alternatives with the parent. If it is a sedation route, are you doing in-office sedation? Are you doing general anesthesia? It can be complex and involved. I think people overlook that when it comes to pediatric dentistry. You think the dentist is just going to pop in, check the teeth, everything's okay because baby teeth are going to fall out anyway. But if a child at age 3 has 8 cavities at that point, those back molars are in the mouth till between 9 to 13 years old. So we need to take care of those because cavities actually spread faster in the baby teeth. So it's something that we want to consider.
So are they spreading faster because the teeth are just more immature?
They're built differently. So the
Okay.
enamel in the teeth is thinner than it is in the adult tooth. So it's going to go through the enamel, the outer protective layer, into the second layer, the dentin of the tooth, and then to the nerve of the tooth, which we ultimately want to avoid because that's when it can start to hurt. It can start a little earlier too.
Fascinating. Okay. These are things I didn't know. This is why I have you here. This is good. So if a parent is feeling overwhelmed, I guess what would be your best advice to them to sort of break down the sort of bigger, like, I want my kids to have great teeth. I want them to not have any oral challenges as they get older, but they're feeling overwhelmed. And it could be just because they're overwhelmed because there's just more specialists, more things that they're navigating. What would your best advice be to them to sort of manage that overwhelm and be able to focus on just one thing at a time?
Yeah, I think that's huge. Taking it step by step. Often at the dentist, we're seeing one parent bring the child in. We relay information, and then it gets communicated to the other parent, and we have to have the conversation again. So, I welcome that. I want to be on the same page as the whole family for what the plan is moving forward. Especially, this is such a common thing that we see. Like I said, with 3-year-olds coming in with a full mouth of cavities, parents are shocked, they're jarred, they're ashamed, they're upset, they're frustrated. Totally get it. That's why I'm big gung ho on prevention. But breaking down a step by step plan, talking about the different alternatives, knowing that you don't have to make a decision that day. I urge parents to take a little bit of time to figure out what their ideal looks like, what is possible, what's feasible. Is your child going to be able to sit in the chair for treatment? We both have to be realistic. All 3 of us have to be realistic, the provider, the parent, and the child. Because again, we don't want to traumatize the child early on just to get
Right.
cavities filled. We want to have a long-term healthy relationship for dental and oral care. So having a full, well-rounded conversation and open lines of communication with the dentist because they want to be on the same team with you and make a plan that you're happy with.
Yeah. And I think that I'm glad that you mentioned all 3 of those people because I know there have been times with our son when he would get ready to undergo a procedure and they would say like, we need x-rays. And I'm like, you know what, today, because we've done so many things, we're gonna
Yeah.
pass on the x-rays. Like it's too much. You know your child the best, but to say like, let's pass on that and we'll do it next time, or we'll come back in a couple of weeks. But sort of having that good conversation to say like, hey, I'm seeing that we're almost reaching the end. And at the same time, I don't want my child to fear a specialist. I really want them to trust that person. And when you push them too far, it can take a while to sort of dig out of that trauma and dig out of that before they'll willingly come back to that dentist again or that particular specialist. So thank you for mentioning that.
No, 100%. And I think you hit the nail on the head. You know your child best, and being their advocate in a situation, you can read them so well. And being able to translate that to the dentist or provider is so, so important across all specialists. That's not even dentist specific. So I love that.
So I'm going to go back to the NICU professional at the bedside. If there's something, Dr. Lerman, that they can do to sort of model, these are some things that you can do with your child when it comes to oral health, or these are some things that we can do at the bedside, maybe to desensitize the mouth so that it's not so difficult as they work through different specialists. What are some things or education that they can do at the bedside with the parents, or even things that they can do with babies that might help long-term the oral health of that baby?
I love that question. And this is exactly why I do what I do. Just we work a lot with maternal oral care and dental oral care. So early on, you can introduce a muslin cloth, something soft, even a clean finger. And after feeds, you can just rub the gums after. Something as simple as that, just to build that in the routine for the child and the parent. I think as a specialist, you have the opportunity when there's no disease on the teeth or in the mouth to tell the parent, once that first tooth comes in, toothbrush, rice, or smear size amount of fluoride toothpaste. When you have no disease, you have opportunity to prevent disease. And I think that's so, so valuable. And when it comes to NICU families, there are obviously so many more pressing issues, pressing matters, and I totally get it. Dental care falls to the wayside. It should. But something as simple as brush that first tooth when it comes in is something that people are overlooking, and it's very powerful.
I hadn't even thought about the no disease. How did you say that? The no disease how did you say, you were saying it was really good. You were talking about when there's no disease. It was really good.
You can prevent disease. Yeah. When there's
Yeah.
no disease, you can prevent it. That's just the ultimate form of preventing disease. And I think that's wildly powerful.
That's really good. I need to write that down. Okay. I love that. All right. So when we think about like what pediatric dentistry is now and what pediatric dentistry could be, like if you had to dream a little bit, what would you say? Okay, so we're doing these things now, and I really love that we're doing these, but in 10 years or 15 years, I would love it if we could do this, or these are some things that are sort of on the horizon, and I know that they're about to really change the face of pediatric dentistry. What might some of those things be?
Yeah, I think the interprofessionalism is huge. Working alongside pediatricians, working alongside OBs, talking about maternal oral health and how it can be connected to fetal outcomes, preeclampsia, low birth weight. People don't think about that when it comes to oral care. So to be able to introduce 2 bullet points about oral and dental care at those levels so we can prevent disease rather than once we see a brown spot in the mouth, that's when they're going to the dentist to get a cavity filled. I just know we could do so much better. And we're already seeing that. So I think shifting to a prevention mindset and intercollaboration among different specialists is really where the future will hold. And I'm super excited about it. I think it's going to have great, great resounding effects.
So what's been like your best day as a pediatric dentist? What was your biggest win?
This one always sticks out to me. I remember it was a 4-year-old. He had his back molars touching, and at a visit, he had the start of a cavity. It wasn't large. We talked about all of the options for the dad, either treating it, taking an x-ray again in 6 months. He was gung-ho, never knew he had to floss or a teeth touch. He wanted to take the x-ray again in 6 months. He came back in 6 months and said he flossed there every single day, was so hyper aware of dental care. And we compared the side-by-side x-rays. Cavity hadn't changed whatsoever. And he felt really passionate about not treating it. He didn't want to get it treated. And you'll find some providers who will say, let's fill the cavity, doesn't matter. My personal philosophy, and there are others who are more conservative, will say, let's keep flossing, let's keep the diet and behavior reeled in, and we can continue to watch this for as long as possible, ultimately and ideally until it falls out. So I think once you get the parent on board and motivated, it could be really, really powerful.
I love that. I think sometimes we walk into a specialist office and we think, okay, so I'm here. This is the problem. they're going to tell me how to fix it, and then I'm going to do what they say. And there's less dialogue. Not that what they say isn't valuable or probably may not even be the right thing. Like they probably know the best way to handle it. But this dialogue about how we can do it together, I think is really good. And it seems to me, at least in the last, our preemie's now 15, there has been a little bit of a shift in now we're considered an important part of the care team. Like it used to be that I was just I was the Uber. I was the Uber driver for my kids and we would go to the specialist office and they would give us sort of the plan of action. But now it's like, here's the plan. How do we feel about that? And could we delay that? Could we do that differently? Could we go to a different specialist? Could we postpone that? Like, I feel like that's a bigger part of the conversation than it used to be.
It's a huge part of the conversation. We need to see what families are willing to do, what they're not willing to do, what that looks like behind the scenes at home. And that changes for every single person rather than see whole, fill whole, you're out of here, come back in 6 months and we'll see what it looks like. Like there's so many individual factors at home that we can play with and talk about. And I don't think parents were historically given those tools as much as they are now. And I think it's getting even better moving towards the future.
Yeah. So when it comes, Dr. Lerman, to sort of implicit bias when it comes to specifically pediatric dentistry, how do you help bridge the gap in people that either have access to care or don't have access to care? And then when they do get access, how do you make sure that they get the very best care possible that they can to certainly improve the health of their baby and also the health of their oral care?
Yeah, I think messaging is really, really important around this, getting all providers on the same page for that first dental visit, ideally being by age 1, but earlier the better so we can prevent disease in terms of access to care. We want to amplify that. That's hugely powerful, being able to get someone into the dental office, not just getting them into the dentist's office, but also giving tools for what they could be doing at home better in terms of diet, nutrition, not having the bottle for long periods of time. So it really comes back to science communication, how we can make that digestible and practical for parents to use at home. And I think that will really, really bridge gaps across all backgrounds.
If there's one thing that you could let people know and that you want them to know about pediatric dentistry, what would that be?
That we're willing to work with you and we can get really creative, really fun, and we want to make it work. And again, be on the same team with everyone. We want to be on the same team as the child and the parent. So being able to have that 3-way communication, being realistic and making a plan A, if that doesn't work, plan B, plan C, plan D, going through the steps so we can get to a place where you feel comfortable for your family.
That's good advice. Dr. Lerman, thank you for the vast array of wisdom. I asked you a lot of questions about a lot of things, and you were gracious to answer them all. So thank you so much.
Thank you so much. Amazing questions. So passionate about this, and I'm glad that this is part of the conversation. It's truly, really important, and thank you for the interest.
Thanks, y'all, so much for listening. That was a fantastic conversation. I hope that you'll do me a favor. If you love today's episode, please share it with a friend. You can also review over on Apple Podcast or Spotify or wherever it is that you listen to podcasts. You can also give us a listen and a watch over on YouTube. It's how we reach more NICU professionals. Today's podcast episode is sponsored by Reckitt Mead Johnson, whose mission is to nourish the world's children for the best start in life. For more than a century, they have led the way in developing safe, high-quality, innovative nutrition products and continue to push the boundaries of nutritional knowledge with consistent, strong investments in scientific exploration.